All right, you guys ready? I'm Shawna. I'm one of the fourth years, and I'm going to present Grand Rounds today on electrosurgery, a commonly used, abused, and confused tool in obstetrics and gynecology. So the main portion of the talk today is going to be about the fundamentals of electricity. Very exciting stuff. We're going to spend the most of our time here. And this is important because I want you to be able to understand the tools that we use and how they work and why they have certain tissue effects. We're also going to talk about some safety considerations, and then hopefully I'll be able to apply some of this to our practice. Following today's presentation, you'll all be able to describe some basic electrosurgical principles, identify potential hazards encountered in the operating room, and I'm hoping that you'll revise some of your current practices and apply your new knowledge of electrosurgery to your patients. So let's first go into the terms, definition, and basic electrical concepts. And this is dense physics, kind of boring stuff, but bear with me, and hopefully at the end of this everyone will have a little better understanding of the tools that we use on an everyday basis. So electricity is attraction of two oppositely charged particles. So you can remember from middle school, we have electrons, which are negatively charged, protons positively charged, and then our neutrons, which are neutral. Movement of electrons is what defines electricity. It's predictable. Unlike charges are going to attract and like charges repel each other. Electricity always seeks its ground. It's very predictable, and it always is going to seek the path of least resistance. You need a circuit for energy to flow. The most basic circuit is direct. This is what is in a battery. We don't use this in electrosurgery. We use an alternating current, and in an alternating current what you have is the positive and negative poles that really rapidly change direction. And when I say rapidly, like a electrical outlet is gonna have 60 cycles in a second, and when we use electrosurgery we're gonna have like megahertz and kilohertz, so that's thousands of cycles, hundreds of thousands of cycles in a second. Let's see. So flow is unidirectional in a direct current and bidirectional in an alternating current. These are a few terms I want to define so that we can continue talking about waveforms and different energy sources. So current's the flow of electrons during a period of time or in a circuit, and current is produced when you have movement of free electrons through your conductor within your circuit. Your circuit is the electrosurgical generator. The current that passes to the active electrode, then to the patient, is dispersed through the patient back to the grounding pad, and then finally returns to its source, the ground, the electrosurgical unit. So that whole thing here, this whole thing is your circuit. And you need a complete circuit to have flow of electrons. Impedance is measured in ohms, and that's the resistance that the current encounters when traveling through the patient. So different tissues cause different types of resistance, and this is based on the water content of the tissue. So like a char, it's going to have really high resistance, whereas things that are very vascular have much lower resistance, and that can have an impact on your power and your voltage. Voltage is the force that pushes the current through your resistance. It's measured in volts, and it's responsible for moving the current through the electrode and through the tissue. And you can see it's related to current and resistance. That's Ohm's principle at the bottom there. And lastly, power is the heat energy that's produced by resistance during surgery, and it's the heat that creates the clinical effects or the effects on tissue. So different waveforms produced by the electrosurgical generators result in different tissue effects. And we commonly have our little blue and yellow buttons on our pencils in the operating room, and we have cut and coag current. And that's kind of, I think, for a lot of us where our knowledge of electrosurgery ends, unfortunately. And so hopefully after explaining this, we'll have a better understanding of these waveforms and the differences in voltages. Pure cut waveform is going to be a low voltage waveform, whereas your coag is a really high voltage. Let's first talk about pure cut. So cutting current doesn't mean it produces a cutting action. So just because that's what it's named, it's really a misnomer and kind of unfortunate that we call one cut and one coag. They're really just describing the waveforms that are produced by the electrosurgical generator. So pure cut is a low voltage, continuous, non-modulated sinusoidal waveform that's produced by the generator. It is used in really two different ways. You can use a non-contact technique, and in this technique you hold your electrode a little bit away from the tissue and you create a spark gap or a steam envelope, and what happens is the current then kind of jumps to your tissue and creates an effect. And this is a really rapid vaporization of the water inside the cells, and you get a clean cut. You get very little coag effect with this technique. If you then use the same voltage, the same waveform, and the pure cut waveform, and you hold your electrode in direct contact with the tissue, you can get a desiccation effect. And this is a coagulation effect. You get vaporization of the cells, and you get you can stop bleeding with this method. In between, we have modulated on-off cycle of these the low voltage cut output. These are our blend modes. So these are the cut waveforms, but the duty cycle has been modulated so that you have an interrupted waveform. With a blend 1, you have 50% of your cycle is on and 50% off. A blend 2, you increase your off time. Blend 3, you increase it a little bit more. And what this allows for is low voltage cutting with increased ability for coagulation. You have varying degrees of current delivery and increased hemostasis without having to use the high voltage coag setting. Coag waveform uses the highest voltage. It's an intermediate waveform. It's modulated about 6% of the time the cycle is on, and then 94% of the time the cycle is off. It's during this resting phase that you're getting the coagulation that's responsible for the cells being able to cool down and for you getting that charring type effect. Again, you can use the non-contact and contact technique. In a non-contact, what you do is you hold your electrode slightly away from the tissue and you get sparking of the current from the electrode to the tissue. This is really good for like superficial bleeding and oozing. This is what's described in a lot of the literature as the best use of your coag waveform is a non-contact technique. And then contact with the tissue in a coag waveform would result in a desiccation and protein coagulation and drying out of the tissue. So we talked about waveform. There are some other things that you can alter to change the impact that you have on your tissue. One of those is your power setting. So this is set on the electrosurgical generator, and you want to choose the lowest power setting possible to achieve the desired effect on the patient's tissue. And this can be based, you kind of base this on your patient's characteristics. So like a really emaciated patient, you may need a higher power setting than somebody that has a lot of lean muscle mass. Additionally, the distance that the active electrode has to, or the current has to travel from the active electrode to the patient can change the power setting that's required to have the same clinical effect. So we vary our waveform, we vary our power setting to create impact on the tissue. We also can vary the size of the electrode. So there's a picture of just some various pencil type electrodes that are available. There are a lot more, and then we also have, you know, bipolar instruments, but those are just a little sampling. As the geometry of your active electrode changes, so as you decrease the surface area of your active electrode, it allows you to have a higher current concentration, a higher density. And this is safer for the patient because it allows you to decrease your power setting, which can decrease stray voltage, as we'll talk about a little bit later. So the geometry of the active electrode correlates with your current density and can be manipulated to create different effects on the tissue depending on what you're trying to achieve in your procedure. Dwell time is the length of time that you activate the electrode on the desired tissue. And one thing to remember is the longer that you're activating that electrode, the more thermal spread that you're creating. And that could potentially be a good thing, but it can also create adverse effects. If you're really close to the ureter and you're trying to take care of some endometriosis, you don't want to have a bunch of thermal spread because you could potentially cause an injury that might not be detected at the time of your procedure, and the patient could return later with problems. Same thing if you're on the pelvic sidewall and you have all that, you know, precious vasculature behind there. You don't want to have a lot of thermal spread. So your dwell time is important to think about. You want to be on your tissue long enough to create an effect. You know, we've all buzzed a bleeder that's continued to bleed and we've had to go back and get it again. But you don't want to cross the line and create too much of an effect and have potentially adverse impact on surrounding tissue. Manipulation of the electrode can allow you to have a different tissue effect. You know, whether it's non-contact or contact technique, we see predictable effects within cells depending on what temperature you reach when you're performing or using these energies. When you reach 50 degrees Celsius, you get irreversible cell damage. Once you get to 90 degrees, you get denaturation of your proteins, vaporization of all the water within your cells. At 100 degrees, you get tissue vaporization. At 200, you start to see charring of the tissue and carbonization. The type of tissue impacts what effect you're going to have when you use your instrument. So this goes back to resistance. Each type of tissue has its own inherent resistance, and that's mostly a property of water content of those tissues. However, as you're desiccating the cell, as you're drawing out the cell, you're changing that tissue's resistance as well. So, you know, each tissue has an inherent resistance, but additionally, they're dynamic as you are creating an effect with your electrosurgical instruments. And the last thing that can have an impact on your tissue effect is this carbonization that results on the tip of your electrode. We used to really use those scratch pads a lot, and it seems like a lot of places have gone away from that because you get the little grooves in there and they become really difficult to clean off. A lot of the electrodes are now coated with like Teflon, and they're a lot easier to clean off. And like I was saying before, this carbon on there has really high resistance and can make it so you have to use unsafe levels of power to get the tissue effect that you'd like. So a little bit about monopolar and bipolar. I've mostly been talking about monopolar, and the big difference is the location of the pole. Monopolar really has two poles in a way. One can be considered the electrosurgical generator, and one the active electrode that you're using on the patient. And then the big difference is with bipolar, your two poles are actually located in the instrument, and so you have much less distance that your circuit has to travel. We use monopolar, I think, more frequently because you have a really wide range of tissue effects that are possible by altering the waveforms, and the tissue effects are a little bit more powerful. That being said, bipolar, you use actually 1/3 to 1/10 amount of power to create the same effect, and so bipolar can be safer. And there's a lot of new technologies now that are allowing you to use the cut waveform, which is, like we said, the lower voltage, in a bipolar instrument, and have more of a clean cutting type of an effect, and not just the increased coagulation. All right, so let's now kind of transition to some safety considerations when using electrosurgery. First thing I want to talk about is current concentration, and how a higher concentration or a dispersed concentration can have varying effects. So at your active electrode, you have a really high concentration of current. That same current has to return to the electrosurgical generator. And so the way we get around, having a burn at one site and then having no adverse effects on the other site is increasing the surface area. So this picture here shows that you have this really high concentration, and this is where you want to have your effect. And then your pad, your dispersive pad that you place on the patient, has a much higher surface area. It diffuses the concentration of the current and keeps the patient safe. But then think about a C-section when we have uterine atony and we have the nurse frog leg the patient and put Cytotec in her bottom, or you have a bladder injury and you have them put sterile milk in the bladder. Your patient's getting moved all around. They're worrying about getting under the drapes and getting gloves on and all these other things, and those pads can get displaced. That's a huge problem. As the pads get displaced, you concentrate that energy, and you can have bad things like this happen. Burn this poor little baby's butt off. It's a mannequin, if you can't tell. But so in the 80s, there was this technological advancement. If you look at the back of the pads that we place on the patients, you'll see that there's like this strip in the middle, and then there's two sticky sides. And the reason that is like that is the electrosurgical generators are able to, they read both sides separately, and they can tell if there's a difference between the contact quality and quantity between the two sides. If it's detected, the machine will a lot of times make a noise, have a light go off, or it will just stop. And that's really decreased this problem for us. Like, I don't know, I've never seen this, thankfully, but that's a good technological advancement that's been made as surgeons kind of recognized flaws and weaknesses in electrosurgery. When you use these pads, remember that they're single use. Even in the same patient, if you have a pad that gets pulled off, you need to get a new one. You want to make sure that they have really good contact on the patient. For us, because we normally operate in the belly, we usually use like the thigh. You want a really well vascularized muscle that's close to your surgical site. Ileana's husband probably isn't going to use the thigh. He's going to use something a lot closer to the patient's head because he doesn't want to increase the resistance, the amount that the current has to travel back to the pad, because that's going to increase the amount of power that he's going to have to set the electrosurgical generator at. And then this picture here on the bottom just talks about like alternate site burns. So this is a like a electrocardio monitor that's placed on the patient. And remember, electricity is seeking the ground. It wants to go back to its source. If there's, for some reason, a block or slow return to the generator, which doesn't really happen anymore now that we have these pads that are able to kind of sense that, the current can seek alternative sources and you can get burns. That's why we tell patients, like, no jewelry and stuff, but it doesn't really happen anymore with, thankfully, the advances that we have.
So, if we're in an emergency situation, you don't need to get the nose ring out or ear ring technically?
Correct. They're still going to do it. I think it's just like so ingrained in like the procedure and how we do things, but it's not an issue. You're going to seek the ground as long as you have the grounding pad on. I think in bipolar, it could potentially be an issue if you don't have a grounding pad on. And for some reason you had stray energy. But in monopolar, where you have a big circuit and you have the pad on, it's not, those things are not an issue. Pacemakers, all that stuff. This slide is relevant for us. So this is really kind of the one thing that I want everyone to take home. When you grab a hemostat and you get a bleeder, what does everyone do? What setting on your pencil do you use to coagulate that bleeder? Right. And you really should use cut. It's a lower voltage and it is safer, and as we have already seen, it can create desiccation, it can create coagulation. It decreases the risk of injury to yourself. One thing to remember also, don't activate that pencil in the air. Make sure it's securely, you have good contact with the hemostat before you hit the button, and hit cut. And that's the best way to coagulate a bleeder the cut wavelength. Because that can create just an injury to you, like a hole in your glove, or can create just stray current. So what I've read is that the hole in the glove that's not why you get the injury. So it's not a pre-existing hole. The hole is created when you have the arcing and you have the stray current. So a hole in your glove is not going to make it so that you get an injury when you're buzzing a hemostat. So everybody use cut. All right, a couple things about minimally invasive surgery. So as we have technological advances and more of us are trying to perform these surgeries in a way that gets our patients back to their normal activities sooner, you're going to obviously run into more complications. You do more procedures, you see more complications. So we have a responsibility, if we're going to perform these procedures, to be able to take action and try to decrease those complications if we can. So just a few things that you can do. You want to inspect your instruments carefully. So this, I'm kind of transitioning to more bipolar instruments and a little bit less of the pencil and the monopolar energy. There's a lot of different technologies out there, and most of them have like a little active electrode, and then they have the sheath that covers the instrument. Some of these are single use. Our monopolar pencils, those are all single use. They throw them away and they just change the tips. But a lot of the bipolar devices are expensive. So, you can use them a set amount of times. Maybe it's 10 times, maybe it's more. But what you want to do is make sure you know how many times, how many uses your instrument has, and make sure that your surgical, your OR staff and everybody is aware of that, so that you're not overusing these instruments, because that can result in a breakdown of that insulation and potential harm to your patient.
Okay, that has been happening. So everybody should pay attention. It's been happening in spatulas a lot. So when you are doing a case, remind the attendings, because we forget sometimes we focus in on something else. But the insulation on the spatula has been coming off. He was over the other day. It was like frying the crap out of way above what we were trying to do. That's exactly what Shawna was talking about. So when you get out, because all you got to do is touch that insulated part. All it's got to do is straight. Just a little bit louder or something, you're burning the hell out of something else. So that's a very real thing that happens a lot.
Don't they have instruments that actually help check for insulation?
I know, like with
Yes,
the
they do.
robot, it tells you, like it has a little computer thing in the device, and it tells you like, okay, we have this many uses left. But I don't know for
Yes,
And
there are.
They have a device in the OR that checks insulation.
It's supposed to check the insulation,
Yes.
but if your scrub tech is using it or not, or knows how to use it or not.
I don't think they're using it.
Yeah, there's a device that's supposed to check the insulation.
Yeah.
And it's your responsibility, obviously, if anything happens to your patient. So it's just something to consider. And also, even though they have a number of uses, if you have a really hard case and you're moving instruments in and out of trocars and changing positions, you could potentially make that insulation wear faster. So just be aware of those things, and pay attention to what you're using when you're taking care of your patient.
The place where it comes in more is if you take like some of our graspers, you can hook up power to like a Maryland tip or all these things. Where you really want to be careful is if there was some break in the insulation. That's where they talk about when they're discussing this. Is some break in the insulation way up high on the instrument, and that's where they do have things to check that. Because that you could potentially be touching bow. You were focused in on the tip of the instrument and what it's touching, but a lot of times, the middle of the instrument or somewhere else, or we're using the instrument to retract. We do that a lot. We put things on torque and use the whole side of an instrument to, if there's power hooked up to that, it'll travel right through that break and burn whatever it's touching.
Also, to avoid injury, try to use the lowest power setting. I've said this a few times already. I'm probably going to say it another time or two. But look at your patient. You can always have the circulator turn your power setting up if you're noticing that it's not creating the desired effect. But increasing power, having power a lot higher than you need it, is another way to just have straight energy and to create problems. Use the lowest voltage. So if you can, use your cut waveform. That low voltage tends to decrease the chance of you having the straight energy as well. Brief intermittent activation is going to create less problem than you putting your active electrode on a tissue and then just holding it. Like I talked about a little earlier, if you're near the ureter, you don't want thermal spread. If you're by the sidewall, you don't want thermal spread. You don't want to injure unintended tissues, and having too long of a dwell time can do that. Don't activate in an open circuit. So, there's the non-contact technique. I'm not talking about that. You're very close to the tissue when you do that. You don't want to activate when you're, several centimeters away from your target tissue, because that can create sparking. Use bipolar when appropriate. It uses 1/3 to 1/10 of the voltage that you use in monopolar. So if you have an appropriate device that you're comfortable with and that will do the task that you're seeking to do, try to use bipolar. Don't mix your metal cannulas with plastic insulation, and we're going to talk about this in a few slides, but what it does is it holds the charge in the trocar and creates an electromagnetic field, which just holds energy, and then it can be released at a time that you don't want it to, and it can harm another tissue and create problems for you, usually that are unrecognized at the time of surgery. These patients come back with like bowel perforations later. So Dr. Barrow was kind of just talking about this. Zone 1 is your only intended place that you want your energy to go. This is where you're acting on your tissue. This is where you want the damage to happen. But there are other places in the instrument that could potentially have energy released from them. Your zone 2 is your insulated part of your instrument. That's where you need to be inspecting. That's where you don't want there to be any breaks. You don't want any of your current to get through there. Zone 3 can be a problem as far as capacitance if you have a non-metal trocar. If you're mixing a plastic trocar with a bipolar instrument, that can sometimes create those electromagnetic fields and be a problem. And then zone 4 is outside of the patient's body. So again, this is all minimally invasive that I'm talking about right now. Direct coupling is going to happen when you activate your electrode and your camera or your suction irrigator are in close proximity and you injure your bowel or your bladder. So a lot of times, say you have the active electrode, your assistant has your suction irrigator, and they're trying to scoop bowel out of the way, they're trying to be helpful. Well, you're not controlling both those instruments. So if you're not careful and you touch and the suction irrigator is on bowel, you could potentially have an injury. You may recognize it at the time of the surgery, or the patient may come back later and be septic or really sick. Insulation failure, this happens in zone 2 when you have a breakdown of that coating that's on the electrode. You know, that the instrument, it's a conductive instrument, usually the whole thing, and the only thing that makes zone 1 and zone 2 different is that you have that insulation on there. And so what can happen is, if you have a really high voltage, you can have the spray or the spark of energy, and you can cause injury. And then a capacitor is made when you have a metal cannula and you have like an insulator that separates like two metal, two conductive things. So, you know, you put your metal instrument through the middle of a trocar, and then say there's an insulated sleeve, and then the trocar itself is metal. That holds a charge. It creates this electromagnetic field, which instead of being able to disperse through the tissue and like the grounding pad, you know, disperse the energy and make it so that there's not an injury and so that it's not an issue for the patient, you get this charge build up, and it can then kind of discharge or spark at another point and cause injury. It can spark to another instrument, or it can spark just to the bowel on its own. The last safety thing I want to touch on is the smoke that's created when we do these procedures. I mean, you can walk by the labor unit and you know there's something going on. You know someone's using the Bovie. And research has really shown that the smoke that's created when we do electrosurgery is really similar to that created in laser, and that there's like DNA viruses and bacteria, there's carcinogens, there's these irritants in there. And really we're supposed to be using universal precautions when we operate. There are a lot of devices out there that can help clear the smoke and make it safer. This isn't an issue for the patients, it's an issue for us. It's an issue for the nurses. You know, long-term effects, I don't think that there's any good studies that really show harmful effects from the stuff, but you know, it's carcinogens and irritants and bad crap in there. So protect yourself and advocate for some of these devices. They have these little vacuum things that go on the pencils and they'll help clear the smoke. And they have smoke evacuators and laparoscopy that go into like the vacutainer systems and stuff. So just think about this and advocate for it if possible, if you are at a place that can potentially accommodate your desires. Last, I want to kind of bring everything together and apply this to something we all know about. When I think about electrosurgery, I really think about hysterectomy, but I wanted to just talk about something that I thought everybody would be really familiar with. So we're going to just apply some of these principles to a LEEP. And I want you to just kind of recognize that you can do a big hysterectomy with the cut mode and a pencil by just changing your tip, changing your dwell time, changing you know, the tension on the tissue. Like you can perform that big surgery with a really simple instrument. And so that's kind of neat, you know, you change all those variables and you can do something pretty complex with a pretty old technology. That being said, there are new technologies which make it easier and which should be explored. But let's just talk a little bit about LEEP. So we're going to kind of hit back on some of the principles I've already talked about. The smaller the wire, remember that slide I showed you before with the little triangle, the decreased geometry, the decreased surface area, you're going to have increased current, you're going to be able to use less power, it's going to be safer for the patient. A good, cleaner cut is what we want in a LEEP, right? We want to look at the margins. We want the pathologist to be able to tell us what our margins look like. We want them to be able to tell us if the patient needs to come back and have more procedures. So you use a fine wire to do the procedure. You also want to have the loop activated before you touch the tissue. If you take that loop, bury it in the tissue, and activate it, right away your power just plummets, and you're gonna get more of a coag effect and less of a cutting effect. And this is gonna make your margins hard for the pathologist again to decipher. So to avoid that, activate your loop just before touching the tissue. And I'm not talking several centimeters away so you have an open circuit, but like just before you get to the tissue. And then what you'll have is this nice, it should flow like butter, like it should just kind of cut really nicely through the cervix. You shouldn't have stalling. If you try to rush through the tissue, what'll happen is you'll have a nice big section on this side, and then this side will be a little triangle because you're trying to pull the thing out of there. So, you know, don't rush it, activate before you get to the tissue, and really let the electrode kind of do the work for you. And then one thing I thought was kind of interesting, considering Dr. Cooper's new LSU themed speculums that we have in the clinic. So you think that they're coated to prevent burning of the vagina, but really why they're coated is to prevent you from having two conductive instruments. So you have your wire electrode, which is a conductive instrument, and if you had a metal speculum, that's going to be conductive as well. So what can happen is you can get sparking of the voltage, the current from your instrument to the speculum. It's not going to burn the patient, but what it's going to do is it's going to change the hertz. So you're going to go from a megahertz or a kilohertz radio frequency to possibly something that's around 60 hertz. And then your patient's going to have muscle contraction. They're going to have something you don't want when you have an active electrode inside their vagina. So we coat our speculums and inspect them and make sure that they don't have any chips in the coating, because if there's a little chip, they can have that and your patient's going to not be very happy with you. A couple things that I just think are interesting. So I read about using saline, which is a conductive solution, as a safety ground. I've never seen this done. I don't know that I'd ever do it, but I just thought it was interesting. So you can fill the abdomen with saline, a conductive solution that can help disperse the current. And that way, you know, you antibirth the uterus, you lift everything up out of the water, out of the saline. And if you were to have like stray current, if you were to have an insulation failure, it would protect the bowel from injury. This is not going to protect the bowel if you activate the electrode and slam it into the bowel. You're going to get a burn. But this will protect from like spray current if you're having to use high voltage. You know, if you're using monopolar and you're concerned. So I've never seen it done, but I guess potentially you could all try it.
This is when you're using the robot or anything and you have a bipolar and you get into bleeding. That's why it's always real, you know, when we're using in the robot and you cut the pedicle too soon, it starts bleeding all over the place. You can never get it to stop. And this is the same thing because the blood is dispersing all the charge.
So it's a kind of neat principle to think about. And then for tubal sterilization, you actually want to use the cut mode. We all think, right, you want to use coag, right? Because you're trying to like make this thing not patent anymore. You want to burn it all up. But actually, if you use coag waveform with tubal sterilization, what you do is you so quickly cause a char superficially that the current can't penetrate into the inside, the lumen of your tube, and so you get more failures. So if you're using monopolar for a tubal sterilization, it's actually best to use the cut mode. This doesn't apply to bipolar because you're using a lower voltage and that's a little bit different. But if you're using monopolar and you're performing a sterilization, actually cut provides better desiccation.
Are you always using bipolar?
I don't know, I haven't even done a tubal here.
Yes. Yes.
It's always bipolar.
Okay.
It's been bipolar since 1980, okay?
Well, so apparently it's not an issue, but I just thought it was interesting and kind of something to think about. And then in hysteroscopy, when you do hemostasis, it's best to use a cut mode and do a non-contact technique and have kind of sparking or fulguration to the tissue, like when you're using a roller ball. Lastly, there's not a particular system out there that's the best and is going to work in every situation. I think it's important, especially for like the 3rd and 4th years, when you leave here, to remember to utilize your sales reps. They can, I mean, their main job is to sell you things, but they also can provide you a lot of education and can provide you demos of a lot of these instruments that we may not necessarily get exposure to. You know, there's the harmonic, which uses ultrasonic energy. And if you haven't been exposed to that, you don't know that they stay really hot and you can't sweep bowel out of the way with the harmonic. You're going to get a bowel injury. Whereas with the ligature, as long as it's not the advanced with the tip on it, you know, you can use that and right away sweep bowel out of the way, and the bowel's not going to get an injury to it. And those are things that you're not necessarily going to learn if you're not exposed to the instrument. So when you leave here, remember, like, education is continuing. You need to utilize people in the community, utilize your partners, and get yourself exposed to these different modalities so that you can provide good patient care. You know, if you're going to do minimally invasive surgery, then you have a responsibility to explore the technologies. And you know, sometimes they want to make money, but sometimes these advances are because a surgeon saw a shortcoming in an instrument, and so an advancement was made, and you know, potentially can provide a safer alternative for your patients. There's some really cool vessel sealing devices, and I didn't talk about them, but they're really neat, and they've made it so that surgery is a lot safer. And I guess that's it. Any questions?
Can you explain how the vessel sealing devices work for all the residents who don't?
So what they do is usually they can use them up to 7 millimeter vessel, and it has this feedback, so it senses the resistance in the tissue and like sends that information back to the generator, and based on the resistance that it gets, it continues to seal until it gets to a certain point. And I don't know, that's it.
And they pair that with the beeps that y'all hear. That's the different resistance in the tissue. And when it gets to that final beep, then it does not send any more energy through the bipolar device. So it automatically regulates it for you. That's why I always tell y'all, sometimes you put it on there and it goes forever, and for some reason it's not, I tell y'all to pull it off because something's wrong in the circuit and it's not reading it correctly. And some of those devices, you can hold them on there and it'll never beep, and you can take it off and the device got really hot. I've melted an end seal like that before. You have to be really careful.
Does anybody have any questions?
That's not really a question, but it's just an observation. One of the things, these instruments get really hot, and I think we appreciate it with the Bovie, especially when you're operating and you're using your attending's hand to Bovie on or whatever, where it tends to get warm. But you don't appreciate, even in the simple tubal ligation where we're using bipolar energy, you may see it kind of popping on the tube, but you lose the sound. You can't hear that tissue being desiccated. And I've had the opportunity once to do a tubal ligation actually through the vagina, and we used the bipolar instrument to do it, and I mean, it kind of surprised me how loud it was, and that instantly told me, man, that thing's hot. And so you have to kind of consider some of your sensories are taken away from you, and you don't necessarily know it. Visually, certainly two-dimensional is a little bit harder, but sound is another one. Tactile is certainly, but those do become important, and you need to appreciate these instruments that you do utilize, because they cause a lot of injury. But that one vaginal tubal made a big impression on me as far as how hot these instruments really get. So there's just something to keep in mind.
If y'all would like to use different instruments, y'all just always ask. I like what I like. We have other things on the shelf. And, if you want to use I don't care for the ligature too much because it doesn't have a whole lot of grasping power in the tip. The tissue tends to slide out. But if y'all want to try the harmonic or different things, we can. And just to go back to what Shawna said about reps, when I first got out, that's how I kind of figured out what instrument. I went to a couple of courses, and where they would have, I recently went to a course where we had a cadaver lab, and we could use an instrument in that, and so you got a whole lot of practice with it, and something that we're going to cause any damage. And so I would encourage y'all to take advantage of that when y'all get out, and get to know y'all's reps, find out what your hospital uses, talk to the rep, and if there are courses available, a lot of times they'll pay for you to go out there, and especially if it's like a cadaver lab or something like that, to take advantage of that.
Thanks.